Good afternoon, everybody. I'm Craig Thornton, Senior Fellow here at Mathematica Policy Research. I'm really heartened that so many people came to this event, either here in person or online, given its rather wonkish subtitle, Understanding T-MSIS. Now, if you're here, you recognize the acronym, and maybe even before you saw it on the screen, you knew that it stood for the Transformed Medicaid Statistical Information System. But what you may be surprised to learn is that even though this is kind of a, seems like it could be a narrow topic, a very technical topic, we have over 500 people, or almost 500 people signed up to participate in this forum and help think and talk about the future of research in the Medicaid program. And study of the Medicaid program is really at a critical stage right now. It plays a key role in our nation's health system, helps our, many of our fellow citizens, fellow people in the country here, and it continues to grow. And just this past July, there were 72.8 million people getting either Medicaid or CHIP benefits, at least according to the Kaiser Family Fund. I don't have T-MSIS data to answer this question, but that number's up 18% over the last 2.5 years, and if 18% doesn't seem like very much, it's about 11 million more people on the rolls. And the programs, the Medicaid program as it rolls out in states varies enormously, and that variation can just be hinted by the difference in enrollment levels. In Wyoming, there are about 63,000 Medicaid enrollees, and in California, there are over 11 million. So the variation, everything is enormous. And keeping up with the Medicaid program is really putting a challenge on federal and state budgets, but it's also providing a lifeline to many people, particularly people in very vulnerable situations. It's there to finance prenatal care for a mother trying to get her baby off to a good start in life. It's there for parents and children. It's there for adults throughout their life. It's there for people who are struggling to live independently, want to stay at home, but are really struggling to do so. It tries to help all those people and to make that a success, to make the resources go as far as they can and help as many people as possible. It really needs research. It needs us to know what's going on now and to be able to understand how it might change, how we could maybe make it better. So until recently, the available data really wasn't quite up to the task. There's plenty of interesting research done, not that nothing happened, but often left researchers and the people who are in charge of policy look to research for answers. It left them with incomplete analyses, conflicting estimates, and often information looked out of date the day it was published. And so T-MSIS is trying to fix all of these things, no small order, but are an important one to move ahead. And today's forum is going to try to launch the next stage of this process. A lot of work's already happened to get the T-MSIS system up and running and get it improved. But now it's important to have a dialogue between the people running the system, trying to build it and improve it, and all the researchers and the policymakers who want to use this data to try to make the program better and improve the lives of the people that program serves. So that's what we're really going to try to be talking about today. We're going to start with a little bit of the history of the program and talk a little bit about kind of what it could do and get started with that. But then the real point is to open it up to all of you in the audience. There are people online. You can put a question in any time. There's a question and answer widget on your screen. If you're in the room here and you have a Medicaid issue you'd like to have addressed or a data issue you want to talk about, hold your questions to the question and answer period. Or right after we're over here, we'll proceed outside and to the lobby, and there's a reception. You can talk to people at that point as well. Somewhere there was a couple of loose ends we needed to touch base. I wanted to make sure that, oh, here they are. We're recording this forum for be able to share the information more widely after it's over. So if you're in the room, the back of your head may appear on the screen. So please sit up straight or slouch as you think is appropriate. And there will be the question cards to fill out things too. And also, if your question doesn't get addressed today, don't stop there. Send the questions in. We'll get them on to the MSIS team, to CMS. It makes a difference. If the research committee doesn't speak up now, or let's put it more positively, if the research committee speaks up now and gets good information, it will improve the T-MSIS system and the Medicaid program for years to come. So given that it was a long-term process and there's a lot to cover today, I'm going to turn it over to the first of our speakers, Carol Irvin. Carol's Associate Director and Senior Fellow here at Mathematica. As I said, she's going to talk a little bit about the history and the current state of Medicaid data. After Carol, Jessica Kahn will talk. Jessica's the Data and Systems Group Director at the Center for Medicaid and CHIP Services at CMS. And then Vivian Bird, a researcher at Mathematica, will talk about data quality in the T-MSIS system. And we're fortunate to have two really great Medicaid experts to provide some commentary on the first three presentations and a view of where we might go. First, we have Dr. Leighton Koo, Professor of the Department of Health Policy and Director of the Center for Health Policy Research at George Washington University, and Dr. Kenneth Feingold, a Senior Social Science Analyst at the Assistant Secretary for Planning and Evaluation in HHS. So with that, and I think I've covered the ground rules. So Carol, you want to come step up?
Thanks, Craig. I am a longtime end user of the Medicaid data, and so I have the great privilege today to walk us through very quickly sort of the history, where we have come from. And then I'm going to pass it on the speakers, the podium here, to Jess, who's going to talk about what's coming with the future of Medicaid data. And what we're talking about is Medicaid data at the national level. So we're not going to really be delving into what the developments have looked like at the state level at all. So we're talking about national data coming in from all states. And the basic story is, wow, look at how far we have come over time. And we have a long ways to go, but we have really made a lot of progress over the years. Before I really want to get started, though, I do want to acknowledge two groups of people. One is a group of colleagues here at Mathematica who helped me put together this presentation. As most of you know, Medicaid is a really complex program. There is no single person that knows everything about Medicaid. The same is true about data as well. And I could not have put this slide presentation together without the help of Dave Baugh, Henry Iris, Carrie Apple, and Keenan Lang. So thank you guys for helping me with this. The other group of people I want to thank before I get going are the people that, in my mind, they trained me on Medicaid data, and they were some of the first people, or the part of the core group of people that laid the foundation of Medicaid data that we have today. And these include Marilyn Elwood, who devoted most of her career to the eligibility records and eligibility data. Sue Dodds, who did the same on the claims side and service records. And then other people like Ann Shurlow and Maylene Mason. Those people were really instrumental in what I know today. So thank you as well. So let's get going, because I think what you really came to hear is what Jess has to say. So I want to go through this pretty quickly. I think the history of Medicaid data is a story told in 6 eras. And these eras show a really nice progression of how the data have grown and become stronger as the program has become larger and more complex. And this graph, what we're trying to show here is how these eras align with the overall growth in Medicaid, both in terms of enrollment and expenditures. And what I really like about this graph a lot is you can see where the eras have become shorter and shorter as the demands for data and more detailed data have gotten greater. So, era 1, 65, the program starts, and through the 70s. Medicaid starts out as a very small program, really, particularly when you compare it to what it is today. It was focused on, really, it was a state effort. Federal involvement was pretty minimal at that time. That meant also data collection at the national level was also minimal. I mean, the states had to set up systems to keep track of enrollment, do eligibility, figure out how to pay providers, figure out how to claim the matching funds from the federal government, but that was about it in terms of what they really had to do when the program started. So at the national level, there was really very limited information on recipients. Recipients in this world means people who actually use services. And their expenditures. We had no real data on enrollment patterns, and therefore research at any sort of great level of detail was very difficult. I mean, we could still do some descriptive analyses of beneficiaries and how they use in a program like the EPSDT program. But it wasn't until I have to look this up because I don't remember the name all the time. The Select Panel for the Promotion of Child Health was the group that made the recommendations that the Healthcare Finance Administration, the first name of the agency that we now call CMS, was recommended to institute uniform reporting by states of data. So era 2, the 80s. Every time I look at this slide, I keep thinking, the 80s were kind of a formidable time for me, which obviously dates me. But all I can think of is that's the disco area. So this is John Travolta. In any event, Medicaid becomes a larger and more complex program. Things like the home and community-based service waivers are added during this period. The disproportionate share hospital payments begin. Medicaid coverage for pregnant women and infants starts to expand, first as optional expansions and then mandatory expansions. It was also during this time when managed care starts to arise on the scene. And the other thing that occurs during this time is they start to make provisions for low-income Medicare beneficiaries to get them enrolled so that their cost-sharing requirements for Medicare could be picked up by the Medicaid program. Data reporting now begins for the states, and it starts out with this thing called the HCFA 2082 form that the states use to report in aggregate who's using services and what the costs look like. Okay, so most of the people in the research community said, well, okay, that's nice. This is the first time in which we have data on all states. So that's a plus. The minus is that aggregate data is not very useful and is not as flexible as we'd like it to be for research. So it's at this time that the prototype known as the Tape-to-Tape project is launched. It was done in 6 states, at least initially, that represented about 40% of Medicaid enrollees at that time. And then also, as that got underway, then they started to develop what is known as the Medicaid Statistical Information System is starting to develop. And there was an acknowledgement that MSIS data are not really ready for research. I mean, it's still a great resource, but researchers still have to do a lot of manipulation of the data to get to final claims, to get enrollment records correct. And so they started to develop research files, which at the time they called State Medicaid Research Files, or affectionately known as SMRFs. Research now can start to become a little bit more complex. They can look at questions such as how are the enrollees distributed across the different eligibility groups? What does length of enrollment look like, and how does that vary across different groups? The demographic characteristics of enrollees. We couldn't really look at that before until this time period. And then who's receiving services overall and by what type? And then actually, I have on this slide some early findings from analysis using the tape-to-tape data that I mentioned before. And this is really the first time that light bulbs go off that, oh, you know what? Not everybody in Medicaid actually uses services. And at that time, they estimate about 20% of enrollees never use services during a particular calendar year. They also discovered that in New York and Michigan, between 36 and 41% of medically needy children didn't use services. And it was also the first time where we see this notion that people who are the elderly and enrolled on the basis of disability are actually some of our most expensive enrollees, although they make up a small proportion of enrollees. Era 3. One thing I want to go back for a second. It was important here at the very end of Era 2 in 1987, where states were frustrated with the 2082. It was a complex form for them to fill out. And it was in 1987 that CMS, or what was known as HCFA at the time, said, okay, states, you have an option. You can either report your data via the 2082 or you can report data via MSIS. Some states took up that option. So in the 1990s, Era 3, a lot of policy is now starting to percolate and get going with Medicaid. We see really rapid increase in Medicaid expenditures, which makes state policymakers really concerned about the program. There's a continuing expansion of enrollment both for pregnant women and children, also low-income Medicare beneficiaries, ongoing growth of managed care. And this is an issue because initially when managed care first started, it was decided, well, okay, we're not going to require states to submit this data. States had a lot of concerns about submitting records that come out of managed care plans, which we call encounter records. And so it was decided that reporting that information was not going to be mandatory. But now it starts to grow, and the research community is saying, hey, you know what, this limits us. We can only look at people in fee-for-service. And while managed care may be small, it may be an important group here that we need to know more about. It was also at this time policymakers became very concerned about provider reimbursement rates and the adequacy of access and the linkage between those two ideas. And at the end of the era, we had legislation that delinked Medicaid from welfare cash assistance. That was a huge piece of legislation. And then also the establishment of the Children's Health Insurance Program. So what was happening with data? Well, okay, the HCFA 2082, this aggregate data reporting form is still around, and states are still saying this is really burdensome. It's getting more burdensome as the program is becoming more complex. And so lo and behold, MSIS reporting is growing during this period, which is a great thing for researchers. In 1992, we had 25 states taking up the option of reporting MSIS data, and by the end of the era in 96, we had 38. So we had more than half the states reporting that. And then in parallel, we are putting out more and more files from the state Medicaid research files as well. And during this period, colleagues of mine here at Mathematica and elsewhere were working really hard to develop ongoing systems for monitoring the quality of the data and taking steps to work with states to improve the quality of the information that they submitted. So the research now becomes a little bit more sophisticated, even more so. And you start to see research done on Medicaid enrollment patterns, particularly during the early years of welfare reform. It's asking the question, well, what's been the effect of welfare reform on Medicaid enrollment? More work done on service utilization expenditure patterns, particularly looking at disparities across different groups. And I and some other people here at Mathematica had a HRSA contract where we got the state Medicaid research files and did an analysis of cost and quality implications of 12-month continuous coverage. That kind of study would never have been possible without person-level data. So era 4, the first half of the early 2000s. So in 1999, landmark in terms of Medicaid data, all states are mandated to report MSIS data. So now we're getting uniform, detailed Medicaid data from all states. It's at the person level, and now we're actually getting more data elements as well. It's also during this period where they decide they're going to retire the state Medicaid research files and instead develop research files that we now call the Medicaid Analytic Extract, which are research quality MSIS data. And when someone like myself, who's an end user, most of the time, those are the data files I'm actually using. And again, throughout this entire period, lots of ongoing work behind the scenes working on improving the data quality, its completeness. And research becomes even more complex. And this is also the first time when we start to try to link Medicaid data with Medicare data. We also did some linking of Medicaid with data from the Social Security disability programs as well. There's a lot more research being done on the role of Medicaid in the provision of mental health services. Era 5, the second half of the 2000s. This is when Medicare prescription drug coverage begins, CHIP is reauthorized. We now are now seeing a lot of growth in managed care, which complicates research efforts because we're not getting complete data on people in managed care. That becomes a bigger issue now. And we see ongoing federal efforts, though, to help states keep improving the reporting, and there's a lot more focus and work with states to coax them into submitting encounter records and managed care data. It's also at this time when provider IDs become mandatory as well. So one thing about the research that came out of this area is that CMS financed a series of chart books. There were actually 4 different chart books put together using the MACS data to give a broad spectrum of statistics on Medicaid programs. There was another chart book that focused on just the encounter data, sort of doing the same thing, but with the encounter data that were already in MSIS. And then SAMHSA sponsored a chart book as well, looking at Medicaid spending and expended utilization patterns for people with mental health conditions and substance use disorders. We also, research was published that great state-level detail on prescription drug utilization and expenditures, and also provider characteristics. People were looking at, continuing to look at mental health, the use of home and community-based services, and then things like churning and migration patterns of Medicaid enrollees as well. And the Medicaid data, the MACS data files in particular, were being used, starting to be used a lot for program evaluation purposes. So now, Era 6, 2010 to the present, the Affordable Care Act sets up MACBIS, which is the Medicaid and CHIP Business Information Solutions Initiative begins, which has 4 components to it. T-MSIS, which Jess is going to talk about, as well as the other ones that I have listed here. The Affordable Care Act also set up the Center for Medicare and Medicaid Innovation. I mention this because this is a stakeholder that is now another stakeholder that's pushing and demanding more and better Medicaid data. And Jess is going to tell us more about T-MSIS, so I'm not going to cover that because I'm running out of time. But I want to wrap up by saying, I think we're going to look back in a couple of years and say that either Era 7 started last year or this year, but definitely Era 7 is going to be the era of T-MSIS data, I think. And there's going to be ongoing efforts to strengthen and improve the data that are available for research. Medicaid is a really important testing ground for healthcare innovation, and we're going to need data to understand whether that innovation works or not. So with that, I want to turn the mic over to Jess, who is the Director of Data and Systems Group at CMCS. So Jess.
Well, thank you. Thanks, everyone. I'm going to advance here. There's the more information from Carol's great team. So one of the things that really struck me, my mic is falling off. Okay, one of the things that really struck me about what Carol was saying is how when the data was evolving, so did all the research questions. If you're on this webinar, it's fair to say you're probably slightly wonky. It's okay, you can admit it, you're with friends. And so we are always thinking about these questions, like what if we knew this and how could we tell this story? And so I think what was part of the sea change that we're talking about in terms of T-MSIS and the data being where it is it's also that it can't keep up with the questions that we now have. We have way gone beyond where the data is, and that's exciting. That means we have no shortage of things to do. So the basic gist of the change that allowed us to put the T in front of the MSIS is going from a smaller number of data elements to over 600 data elements. And so that's a different, richer story. So I'll give you some examples of what's in T-MSIS that wasn't in MSIS. So for example, data on third-party liability, so we can understand if it's a dual eligible or a veteran or somebody who has other sources of care, so you can start to really look at the totality of who's contributing to the cost and experience and access of care of people. More information about the providers, National Provider Identifier, and some things that are really helpful for us to do linking between providers. There's more information in the eligibility file, and more information now on the managed care plans themselves, not just the encounter data, but about the plans themselves. So it's a big uptick in the kind of data that is available. And it's now also more timely in that states are providing it to us monthly. So of the 18 states that are live today, more than 6 of them are current, meaning giving us their data right now in October for September. It's never happened in the world of Medicaid data that we could run a report and tell you, like, right now, how many people are enrolled, at what demographics, and what kinds of information on a state that's that current, such that there are now people who are calling me and asking, could T-MSIS be a data set for current enrollment for Medicaid? You have no idea how exciting that question is. So that timeliness is really exciting for programmatic and obviously for real-time and rapid cycle evaluation, which has also really moved over the years, I think, towards that. A couple other fundamental pieces is that before, and we would get the data from the states, and we'd have to go through it and compare it to what they gave it to us before and what we understand about that state and go back and forth. You know, why is it like this? This isn't what your trend was. And now we have harnessed the power of technology, and we have built into the system, the federal catcher's mitt, a set of business rules that are applied as the data is ingested that go everywhere from the basic, like this shouldn't be alpha because it's numeric, all the way to these are not valid values for this state. This state told us what its valid values are for that data variable, and this is outside of that parameter. So it's a really wide spectrum, and it's not just then data quality, it's data errors. It could be just anomalies, things that draw your attention. You're like, they're paying a dead provider, okay? The provider could be dead, and this could be a valid payment to their estate, or the provider is not dead, and their data says something wrong, or they paid a dead provider and they really shouldn't have, and now we have a program integrity thing to follow up on. But either way, now we at least made the connection, right? And there's lots of other patterns that we're able to measure in the data set as it's coming in, and certainly even before the states start to bring us their data officially, that gives us a much higher confidence level in what we know about the data. So that's not to say we've hit data nirvana and Medicaid's state agencies have now started giving us perfect, pristine data. Such a thing, I think, is not a valid goal. But now we actually know what's there and what's not there, and we can share with you what's there and what's not there. So that when you're drawing your conclusions and doing your analysis, you'll say, okay, you know, I understand in this data set, 5 out of 6 plans are submitting behavioral health. This sixth one is not. So therefore, I shouldn't make a broad statement to say this is what all of behavioral health managed care looks like in the state, because fine print, I have 5 out of the 6 plans. That kind of specificity you need to have in order to effectively use the data. So that's hugely important to us. And then the last thing I would say here is around the robust data analytics. Carol had mentioned that MACBIS is more than T-MSIS. So the other pillars that we have in MACBIS are fundamental for linking the true story of Medicaid together. For example, states, as you hopefully know if you're interested in Medicaid, have a lot of flexibility through state plan amendments and waivers to do things differently. So how does that actually affect the outcomes that we see in their claims? Well, you would have to know through some other brilliant other source what waivers the state has, and you'd have to go and read their whole state plan, which 6 months later you'll get back to your team and say, okay, now I think I know what the state is doing with their service delivery. Well, MacPro, one of the other systems that we're building under MACBIS, is where states will be submitting their state health amendments and their waivers. So now with one data model, we would actually be able to say, let's pull out everybody who has a 1915C long-term care waiver, and then now let's look at their T-MSIS data and see what's happening for people who had that authority. Let's see how it looked like for people who have fee-for-service versus managed care and all kinds of things. Much easier to do that. And there are 2 other pillars that start to loop in the financial data and the pharmacy data as well. So we have a fuller picture. So it's pretty important to us to have all of those together. Oh, the things we can do. We're like cooking up all kinds of good ideas. This is just a snapshot. Your job, by the way, is to outdo us. There are more of you than us, and this is where your strength is, and where as a community we will make the Medicaid program better, because you'll think of new areas to look at even beyond what we already know we're either already scoped to do or that we should be doing just in the due diligence oversight responsibilities that we have. But clearly it's important to compare states. This is a 51 flowers blooming kind of operation, plus the territories. But that said, part of what the Affordable Care Act tasked us to do was to understand where those differences matter and to find places where a more homogeneous approach is actually acceptable. Where do you need heterogeneity in approaches, and where can you say, okay, this is what eligibility criteria look like. We're all going to use this income standard. Let's adhere to it. And so comparing, though, then what the outcomes are is really important. Understanding where managed care is going and with certain services is really important. We have huge initiatives going on at CMS to improve states' managed care encounter data, what they get and what they give to us. And then same thing on the fee-for-service at looking at access to care. So T-MSIS is an important data set to help contribute to those conversations. Most of the Center for Medicaid and Medicare Innovations demos that have to do with a state have some layer of Medicaid data in their evaluation. Everything from the state initiative, innovation models, the SIM. It's really hard not to speak in acronyms, you know. I should get paid extra for having to spell things out. So the SIM grants, those are more driving towards how can we use health information technology and exchange and those things to really drive better outcomes across payers. That has Medicaid data in the mix. All of our dual eligible demos, of course, have Medicaid data in the mix. So it's a really critical data set for our evaluation, which then isn't just for evaluation's sake. It's to turn around and say, this works, this doesn't work, this works, this doesn't work, this works only in these parameters, and so forth. So we are creating, you heard Carol mention many iterations of the files that were made available of the Medicaid data. I think SMRF should be brought back as an acronym, though. It's definitely a lot sexier than TAF. Sorry, guys. Sorry. My team's like, thanks. But anyway, T-MSIS analytic files are what we are working on. It is the latest version of a MACBIS, a SMRF, or whatever. And so you have some examples here on the slide of what we're focusing on to start with. The idea is, of course, to iterate over time. And we have, you know, every week we're on the edge with some new states coming in, and when they come in, they have to get caught up. And so while they're iterating and giving us their data, we're iterating on how we put these files out. And what's so great about this forum and your feedback is to help us prioritize and understand what's the most consumable way to give you the data and with what kind of content. We can't promise you that we will give you everything that you wanted under the tree, but we can say that that information informs that prioritization. We don't want to put something out and then have everyone go, well, I can't really use that, because that's not the point. The point is to get the data used. So we want to go for the biggest bang for our buck here. We have tremendous demand. Besides the fact that as an administration, we're very passionate about open data. But in general, though, we have tremendous demand because it's pent up, to Carol's point, right? It's pent up now for Medicaid data. It's not like it's been there and there was a little hiatus and it's back. It's like this is much more than has ever been available. So people are thinking of great new things. We get contacted by tech companies, innovation companies, folks who want to use this data to figure out how to improve care, how to help connect the dots between providers and their beneficiaries. Universities who want to do research, other kinds of research organizations like yourselves, oversight, the list is endless. So our open data strategy is something that's underway right now. Okay, so we've done a lot. I'm not going to read the slide to you, but let's just say we work really well chunking things out as a team. And so chunk 1 was just get the data, chunk 2 is share it, and chunk 3 is use it. Though I have to say I feel like now we've merged all 3 into one, and I'm sure people feel like that too, where we're still getting the data and we're already sharing it with some people, and we're doing some early analysis, right? So much for chunking. We decided to put it all together, and that's just the way we roll because everybody's so excited, you know, that everyone wants to see the power of what can be done. So those initial reports and things that we're doing are pretty important. So I'm going to show you a couple tools that we've pulled together that I think really highlight some of the innovative approaches that we've used for T-MSIS. But first, just in case I wasn't already clear, it's live. When I say we have 18 states data, that means in a live federal system that, by the way, sits in the Amazon cloud. And so we think we've not just built it, but we've built it in a very innovative way. I already mentioned to you the way that we are processing the business rules and how we've automated them. And I'm going to show you in a minute some examples of some online tools that we've had that help us and help states keep a close eye on data quality. But if you're an IT wonk, which is probably unlikely if you're listening to me talk about data, but just in case you're, you can talk both talks. This was built with agile development very quickly, actually, and we do lots of small iterative releases to improve it over time, which is something we're also very committed to. And all these slides you'll get, so don't worry about all the fine print. Okay, this is the map that rules our life. This is the map that tells us where states are in their testing. It's not just testing system-to-system connectivity, because that's important, but it's also testing, can they give us the data and it comes through correctly. And so there's some level of technology matching that goes on there. But now what we're also doing at the same time is starting to look at their data early while they're trying to make sure they can give it to us and it comes through and it's not sausage. Can we also look to see that that's actually what we would expect to see from that state, so that they can be fixing the technology and the data at the same time. So what you have in white are the states that are already in production. This was as of 10/3. We had just approved Washington, so they're approved, but they're not technically in production until they start. But as soon as we make these charts, then they become out of date anyway, which is a good thing, good problem to have. And then blue are the 9 states that are currently on the cusp. Those are the ones that, with support from Mathematica, our team is looking at the quality of their data. Because here's the thing, with the exception of a few states, we could double the number of states in T-MSIS tomorrow if we wanted to. But we don't want to, because their data is not ready. And we don't want to give you something that wasn't worth your time and effort to take a look at it. There's a really high bar and high value being placed on data quality here. And that's not, again, to say it has to be perfect, but it has to be good enough. If you can't even do the basic analyses that you wanted to do or that you had been doing with MSIS, it's really not the point, right? So this point where we have them, when we're bringing them on board, is this delicate balance between enthusiastically getting them in, urging them in, but at the same time saying, if you can't break people out by eligibility group, we probably have a problem with your Medicaid data. So we try to get that sweet spot in the middle. And yes, we're leaning on those that are yellow or otherwise falling behind. But it is our expectation that all of the states come in. Okay, so I mentioned we've done 2 cool things in terms of tools to help this along. One of them, we unabashedly borrowed the idea from Texas, so Medicaid, so we always give them credit. So that is as the data is processing, the states could get a real-time view of their data and the flags that are being kicked, all the way down to the data element. So they could look at it by file. Here's my eligibility file. It's going through. It's being processed in T-MSIS. Look at all the flags that are popping up, or in any other file. And they can trend it over time, so they can see, wow, this is a persistent problem, or I already knew about that one. That one's in my plan of action to fix. I'm not going to worry about it. But they don't have to wait for somebody at CMS to call them or email them and say, boy, you have 6 errors that are showing up this month that weren't there last month. They can see it in their operational dashboard. And it has lots of really good tools for them to start to narrow and how they look at what those flags are. And it tells you the exact business rule that you tripped with that data element also. So it's a great tool for states. And we look at it internally also. So here you can see an example of a state error summary, which rule number it picked, and it says the values were inconsistently specified. So it tells them exactly what the message was, how many data elements had that error, and then that helps them triage and figure out what they need to fix. They can drill down and start to look and see if there are relational errors between data elements. If it was wrong here, that means it's wrong there. And this is really quite precise of a tool. And this is why we have such confidence that we can provide transparency on what's in the data and what's not. So that whole point that I made about wanting to use it as fast as we get it instead of waiting for the next chunk. So one of the things the team has already started working on are snapshots. Okay, so what can we say now? And so you have an example here of one that they played around with, and we're always playing with formatting, so don't pay attention to that. The point is the message of the data here, which is for Virginia, which we just pulled as an example. You can see their eligibility groups broken out by age, And by gender, you can see how much was fee-for-service, how much was managed care. You can see what care settings they were in, long-term care or otherwise. And then the map at the bottom shows you the ratio of beneficiary to primary care provider by county, which is very interesting, right? And then on the sources and notes are, because we're good data wonks, all of the caveats and fine prints that have to be there to tell you how we did it and what it comes from and what went into there. So the goal is to start to do things like this. But let me highlight for you what we wouldn't have been able to do if this was an MSIS data feed instead of T-MSIS, okay? So first of all, we wouldn't have been able to make this so quickly based on the data that's there. That's as of December of 2015. We could actually have done it with more recent data. So the timeliness part is critical there. And then some of the eligibility data and the breakouts and the mapping against provider types, we wouldn't have been able to do in the same way. So it's already able to tell us a story. And you could do this then with another state that has different characteristics and start to compare and contrast them. So we love these. There's their age distribution, eligibility. You can see the dual eligibles. Also really important to see that. And then at the top, this is what we consider like the speed dating cheat sheet to know your Medicaid state. Are they expansion, are they not? Are they a marketplace state, or are they not? You know, how many are enrolled? How is that varied over time? How many waivers do they have? It's the basic, like I'm looking for a state for my sample that is X, and you could just look at the top at least to start to filter that down. So these are the kinds of things, a sample of, a summary of who that state is, and a scorecard, if you will, of that state's data quality that we want to make available with the data. You have to have both. You can't just take the data and not have the information on the narrative of what's there and not there in the state's data. Or, I mean, I guess you could ignore that information if you wanted to, but we want you to take the data narrative, the metadata with the data. That's very important to us. This is not our data. We are not the primary data source. The states are. And it's very important that you understand that and be able to take whatever we can tell you about the data, but there's going to reach a point where CMS cannot answer that question, and you're going to have to go back to the state for that question. It might have to do with other things that are happening in the state, prevalence of certain conditions, other initiatives that they're taking, other policy changes that they've made. So eventually the state is the single source of truth around their data, but we want to arm you with as much information as you can. So this just breaks out that snapshot into something that doesn't make me wish I brought my reading glasses. Okay, so looking to the future, as I said, we really love these products. They're operational, these kinds of tools. And these kinds of snapshots, like I said, we have started to share. We are working on this open data strategy, marrying what we hear in forums like this with what we can resource. And we're starting this data quality feedback loop. I mean, it's already happening organically, perhaps not as regimented as we would like, but you know, we have these conversations with people and we say, well, we saw this in the data, and they'll go, that's not right. That's perfect. That's what we want to have, because we're all experts in something different. And so we're all going to look at that data and say, this doesn't make sense to me, or this has a question. That's the only way the data will improve, is if people actually look at it and bounce it up against what they otherwise know about that state and have conversations with the state and with us, and then it will improve over time. And we're also working on additional, as I said, data quality metrics that we would share, and other tools that can help the states move forward. So this is super interesting to us. Another example of trying to use the data before we even have it. Well, we do have it before we have it nationally. So one of the things that has plagued us in Medicaid from a programmatic and policy perspective is it's very hard to have a dialogue about a particular condition or a particular group when you're working with 51 different definitions of what that condition is or what that group. We don't share a vocabulary across states and across the federal level. It is completely frustrating. And so what T-MSIS allows you to do with a single data dictionary is to say, let's take some of these particular areas, let's create an algorithm or two or three that will tell you what those areas are, and then we can all have a single conversation about them. So substance abuse disorder, let's agree that if you use the T-MSIS data dictionary and you run these diagnostic codes or whatever it might be, that this is how we identify our population that is potentially afflicted with a substance abuse disorder. Now that we have all used that same methodology, let's talk about what can have impact and how to make that impact and how to measure that impact. Because if you didn't start off with the same definitions, you'll never get there. So our Innovation Acceleration Program, which is a partnership with our Innovation Center and the Center for Medicaid and CHIP Services, has highlighted these 5 areas. And our team is busy working on tools that they will then turn around and give to states. Here, this is how we think you could calculate beneficiaries with high cost, high need. If you do that, then we can have a conversation across multiple states about what that looks like, and we might get to a point where we can measure things together. So those tools will be really important. So here's some examples. I think one of our team members said she found 20 plus different definitions of a high cost, high need beneficiary, probably 20 different ways to call it, frequent flyer, anyway. So, and so having a single definition is pretty important. And so when you start to look at the data and look at it across Medicaid, you can start to see for the high cost, high need beneficiaries, do they have multiple conditions? What is their percentage of spending? And what's their account for all of national spending? So as I said, standardized methodology is necessary. We can use this administrative data. Yes, I know clinical data is super sexy, but you can use administrative data to define a population in a way that programmatically we can address it better. So I will go through these. You have them in the deck, or you will shortly. But there are a number of different examples in here. So what these toolkits will have is the methodology document. We want to be very transparent. What did we use to actually come up with that so that you can replicate it? The actual SAS code, whoo, how about that? We don't have to pay for it 51 times with mostly federal dollars. We could actually give the SAS code and you could use it, and use cases to have that dialogue. So our team, sort of the data team and the data science team, are partnered with people who are on the more of the programmatic side and the model design and the evaluation. And so this is really important for those two sides to come together. So as far as our open data strategy, I mentioned we're currently working on these canned reports, things like most common drugs, things that had been done before, but now we have the T-MSIS data set to do that. We will just refresh them as we have more states. We are not going to wait to have every state and have some degree measurable by I don't know how of perfect data. So we're going to create these reports and we're going to refresh them with more data as we have them. I mentioned we're already doing the analytic files, and then what we're working on in the near future are more public-facing data products. So we used to have data marts for MSIS. We know there's a high demand to make them available for T-MSIS. We're having some interesting conversations about having an API on top of our data warehouse so that it can be queryable for system to system for some of the use cases that now are only available because the data is more current, and other analytic files and tools. So lots we can do there. So this is the big discussion point, right? This is why you're here or online. And that is, how can we make the data available to the research community, and in what ways or with what content to make that most valuable. So we will get to that discussion point. But for now, there's for questions. I'm a huge Twitter fan, by the way. So another way to get questions and really get my attention, because I get 500 emails a day, is if you use Twitter. So we have @CMSGov is the CMS handle, and then I'm @JustPecan. And I will pay attention. I already tweeted while I was sitting up here and Carol was talking, gave her shout outs. So I think it's important to understand that that's a community also that's very interested in our data. And so either through email, which my 18-year-old says is old school, or through Twitter, or whatever else you choose. And then I put a bit.ly there for our online resources and information that are on Medicaid.gov. And we'll continue to refresh that site with more information. Okay, Vivian, without whom we would be in dire straits, is going to come and talk to you about some of the things that are happening as she talks to states about their data quality.
So just got to share some of the fun details of all the things happening in T-MSIS. And I'm here to share with you some of the ways that we're drilling down into that data to make sure that it's high quality and usable for the research community and others within CMS. So for me, the question in all of the work that we've done and all of the teams that have worked on data quality throughout the decades that I think is the one that kind of resonates with everybody is, do the data really reflect what your program looks like? Sometimes when we're talking with states and data users, we can get bogged down in the nitty-gritty of a particular element or a particular number. But when you kind of cut through all of that and say, all right, what we're really trying to get at is, does this reflect your program? And I have to say that question really cuts through and gets people thinking, okay, you know what? It doesn't, and we're going to look into why that's true. So really what we're getting at is when we look to use the data as researchers, we want to know whether the data that we want to use is available. We want to know whether it's complete, so does it give that full picture of the enrollees and the services delivered within the program. And then when we go to use the data, are they consistent and high enough quality across time that we can really start to answer those questions that we are hoping to answer through our different research questions. And then Jess talked about this a little too, but you know, there has to be a level of transparency. When you have very different programs, which you really do across the 50 states and District of Columbia, when those data are different, when there's something, can you really access that source and find out why that's true? So we've talked about MACBIS, and I'm here to highlight a lot of the hard work that the team, both at CMS and with other contractors and at Mathematica, are doing to make sure that this consistency and quality gets better with this new wonderful data set that's available to us. So a lot of the work that I'm talking about today is being done under the Business Analytics and Data Quality Development Contract, a little bit of a mouthful. But really that piece of the contract is working to make sure that we have high confidence in the data and really create this feedback loop that will not only talk with the states, but also be really germane to this monthly high volume source of data. So I think the data quality work that happened before was very time intensive and really was lagging in the fact that states also didn't have to do this monthly submission. And so we're working on these ways to move forward in the new environment. So the data quality goals are really to centralize all these sources of data quality information. There are so many ways to find out, you know, in particular on different elements and within all of these files, but then also just again, reflecting back what programs look like, there's a lot of sources of data out there and we're trying to centralize. Again, working to really automate the approaches to the data quality, and just talked a little bit about edits, and I'll talk a little bit more about that. But you know, these are big programs and complex and lots of players, so working to centralize that and automate the approaches, and again, inform the stakeholders as we move forward so that folks know what the limitations are and what they can really do with the data. So again, going into the basic edits, Jess talked a little bit about some of these automated ways that we can look at the data. And really, these are things that states do themselves also within the data when they're accepting claims from their providers or enrollment. They're looking to see whether they can pay that claim and using these types of edits. So really, there's different tiers of edits that we can use and employing under the T-MSIS environment. So we talk about data element validation, and so those are really to make sure that the files are meeting technical standards, including really valid values. I mean, that might sound pretty basic, but you'd be surprised that things get into the data in ways that you might not expect. And so having these automated routines really worked into the file processing gives that more real-time ability to see whether the data are flawed or whether there's something else going on. So we look at intra-file consistency as well. We have 8 T-MSIS files now as opposed to the 5 that were in MSIS. And so you want to make sure that not only are the individual fields of data, do they have valid fields or valid characters inside, but is this particular field telling the same story as a different field about that same person? So as an example, I mean, if you have an eligibility record with a pregnant woman, but on a different part of that record it's showing that you have a male, that's something that you're not really going to want to use, and that's something that it might have taken a long time to figure out in our old world. And so using these automated edits, we're able to really immediately flag these types of things for states, and they themselves are doing this type of thing to make sure that the data they're getting, both from fee-for-service providers and from their plans, are meeting these standards for their use. We also are looking at basic edits to check whether the data that are coming in really reflect the benefit package. So, you wouldn't expect a person that has a very limited Medicaid eligibility from some very particular circumstance to suddenly have utilization that reflects a much more robust program that they would be eligible for. So again, just these kind of checks across and within the files help us to see that we are accepting higher quality data that will be usable for the researchers and the data users at CMS and lots of other folks. So again, I have to say, as much as you'd think states doing this internally, CMS doing this as well, there's still things that get through even after those basic edit processes. There are errors that can come in, and again, this is kind of always focusing back on what does the program look like. Some things might be valid within a field and might be valid across the fields and might be valid across the files, but the more work that you do to really understand the data quality and the more use it really undergoes, the more that you might start to see that there are problems, or at least you are alerted to the potential for a problem. So there are also processes being worked in that really test just beyond those basic edits. So we do a lot of things that you would do as a researcher if you were to get a fresh data set, right? You'd start running frequency distributions to make sure that the data are falling within the parameters that you would expect. And not just for a particular month, but over time, right? You wouldn't expect a large blip in data generally, but here's again where the Medicaid nuances come in. If you have a program change, like let's say you're looking from December of 2013 to January 1 of 2014, when suddenly we have a lot of new folks eligible for Medicaid, a basic edit or a very automated process that's not as nuanced would suddenly flag everything and reject it. But we're in a world where we're really trying to take into consideration the fact that these things happen. We know the programs are different. And so we're alerting users and the folks within the team to see what there might be there. And some of these might be justified and some of them might not be. And so the reason we use I use the word infer quality here is that you really are using as much as you can all these resources to really try to infer, is this right? Because you're not always going to have that black and white answer right away. You're going to have to look at the program, the people, who's being served, and what you're really looking at. So those are some of the other types of validation that we look at. And again, trying to routinize these within the data quality work. So another piece, and I've kind of mentioned already, but we really want to make sure that the data reflect the program in the types of benefit packages that a state offers, the really nuanced pieces of their program. And so there are lots of ways to do that right now. Because there are currently more streams of data coming into CMS, we actually use some of that to kind of internally validate data sources against each other. So eventually there'll be a world, and T-MSIS is really there in some ways to try to minimize the types of, or the number of data feeds coming in. But currently, and we can really use those to really compare. So is what you're reporting into the Medicaid managed care data collection system the same thing that you're telling me, so to speak, in the story of your data? Is what you're we're also able to validate against other external sources like TANF recipients and SSI data to say, okay, are the folks that you say are here, are they really here? And so it's really powerful to be able to use all of these data sources to be able to make sure we're telling the same story about the data. So just trying to give you a little snapshot here about the types of measures. Oh, and I was a little remiss in saying, it's not just kind of doing those data fields and even across fields, but we recognize that people bring all of these things together to create measures, right? As researchers, we want to measure things, and we want to make sure that what we measure is accurate. And so a lot of the data quality work is also really bringing a lot of that together to create and anticipate some of these measures and look at them across time. And so wanted to give you a little snapshot of the types of measures and the numbers of measures. that we're using to really look at data quality and really understand the data and how we can move forward in that quality. And over time, again, I think one thing to emphasize that, and we've heard this from states in a lot of our work, is this is a very, this is an ongoing process, right? You start at one side of the spectrum and you hope to keep moving. And so as we hear from users and researchers and internally from business owners, it's important to kind of keep this evolving and making sure that it really reflects what we're going to be using it for. And the more that we use it, the more that these kind of insights into data quality keep coming up. So again, just wanted to give a few more examples of the types of measures and give you hope as researchers that these are things that you're really going to want to use and that you're going to be excited are going to be available to you. And again, talk a little bit about, I think in prior days, these were things, of course, we did look at, but the fact that they're becoming routinized and they're really becoming part of the process, I think, should give us all some good hope about what we're doing. So just to be clear, there are still always data challenges. We have lots of variety in the types of programs and what states have chosen to do through their Medicaid program. So I think, we look at it a lot of ways in this kind of peeling of the onion. And I think it is still important to know that, some states are going to be a little further along in these processes and their data are going to be a little further along in terms of the quality. And that often reflects what's going on within the state. Do they use the data? Do they know that these problems exist before they even get to the federal level? Or is it that they're waiting until someone else is using it before they discover this? So just wanted to kind of point out, there's a new and expanded format. States are working really hard to make sure that they're getting all that data in. They can see the benefits that lie ahead for them as well. But we know that there's always going to be challenges and that we're trying really hard to be a partnership with the states to make sure that they recognize the hard work that they're putting in will also benefit them and the other researchers within the community. So just, again, what's next? We're working really hard as a team and within CMS, within the partnership with the states, and within CMS and within researchers as well, to make sure that we really combine all of these data sources. We supply the information that we do have. There's some exciting business intelligence tools that we're working to implement in the future of the contract. And again, always trying to kind of slice and dice and make sure that we're looking at the data in a way that the end user is really going to find meaningful, and that really creates a feedback loop to the states to make sure that they really know where they can find improvements or where things are not really giving that full picture of their program in the data. And so with that, I will wrap up and happy to turn it over to Dr. Leighton Koo, one of our first respondents.
Thanks very much. Hopefully my mic is working. Is it working? Yes, no, the green light came on. Working? Okay, good. So first of all, I want to thank folks from CMS and Mathematica for setting up this session. It's really been amazingly informative and interesting. I confess I'm a data wonk. I've been doing this for a long time. So you can date me. I go back to era 2. As described by Carol. I used to work for Systemetrics, which was the organization that was doing the tape-to-tape project along with Dave Baugh and some of the others at CMS, and have continued in various iterations of my life at the Urban Institute, at the Center on Budget and Policy Priorities, now at George Washington University, continuing to use Medicaid data. So I appreciate that. I like to think of myself as not just a researcher, but actually a policy researcher. And I guess to me, one of the critical features that is important here, and we've been talking about improving data quality, but ultimately the issue to my mind is integrating data and policy. And this remains a huge challenge both at the federal government and at state governments, is the ability to have the policy people and the data people be able to talk to one another in meaningful ways. It is not all that long ago that I remember speaking to a high-level Medicaid official in a state, and I said, "Are you aware of the fact that you lost 30% of your beneficiaries in the past year?" He said, "What?" no one has told me this. This is the first time they'd heard that. And it struck me, my gosh, there's this huge gap and chasm in people who are making policy not having the faintest clue what's actually going on. And things have gotten somewhat better, though this gap between data people and policy people remains a pervasive problem. I like to think that researchers do help fill in this gap. I can also think of another situation more recently where a Medicaid official from a state called us up and said, can you tell us this feature about our state? And it was sort of amazing to me. It was their own data system that we were getting this information from. How come they didn't know it already and they needed to call someone externally to get the answer to that? It was just astounding. So that being said, the work that has been done at CMS, at Mathematica, at states, and let's face it, going all the way back, this includes managed care organizations, physicians' offices. The truth of the matter is the people who are generating the data at the beginning are clerks and doctors in hospitals all across the nation. So this is actually a huge system that they are trying to change, and they're doing it. That being said, and I will say, I'm impressed. On one of my other ventures, I'm on the board of the DC Health Exchange, where we have had to develop our own system. We are actually proud to say we're one of the 4 states in the country that actually opened the exchange on time, had a data system that has been running continuously since then. Just this past year, we won an award from Amazon Web Services for an innovative cloud-based system. It took a lot of hard work and a lot of people much smarter than me to do that. So, I'm fortunately being a board member, I get to take credit for work that other people did. So I'll take, but anyway, they did the work, so anyway, so everything that's gone on reflects an amazing amount of work and effort. That being said, now, of course, I can't say these positive things without reflecting on some downsides. For another aspect of my life, my daily commute for many years now has been using Rock Creek Parkway. For those of you who live in the area, Rock Creek Parkway, or parts of it, are basically under construction for the next 3 years. What this has meant that there's this promise of a better road that I will have. On the other hand, right now, my commute has just doubled every single day. And so for a number of months, maybe years, I'm going to be really inconvenienced because there's this better thing in the future. And so this is part of the concern that I've had about what's happened with T-MSIS and some of the Medicaid data systems. Medicaid has become vastly more important. But there are some bumps in the road right now, and there's some transitional problems that have led to sort of a lack of data availability now, when conceivably, given the Affordable Care Act and Medicaid expansion, some of these data may be more valuable now than they've ever been. So this causes a problem. And so I don't know that they're easy solutions. I wish that they had a little magical highway that could sort of help me bypass the Rock Creek Park diversion that I'm suffering every day now. It hasn't happened, but these are some critical issues that have made data access tougher. One of the things that Jessica was nice enough to mention is, well, in addition, let me just mention, as a user of MACS data and MSIS data in the past, it's a pain in the neck to use. It really is a pain in the neck. And so hopefully an improved TMSIS system will make it less of a pain in the neck. I suspect it will still be a pain in the neck. And so, therefore, there were important subsystems or sort of offshoot systems. Jessica mentioned the MSIS Data Mart was something that was publicly available, was a fairly easy to use, a little clunky, tabulator that would let you do some analyses. It is a shame that that no longer exists because that made analysis much simpler for a large party of people, both inside and outside the government, who didn't want to get access to the full MSIS type data. And there are other subsystems like that for various things. Another one I just mentioned to Jessica was the Medicaid drug utilization data is offline for the moment. If some of these other systems could be improved, that would be great. There's perpetually been a problem in trying to get access to things like state plan amendment data. So the notion that there are plans to get that policy data about states integrated in and hopefully somewhat current and accessible, that's also a major improvement that has vast potential to help us understand these things. I guess some of the, and I don't think I have a whole lot of time left. What I'd like to sort of also think about, and here maybe there's some questions that I have, things that have been problems and gaps in the past, or again, thinking forward. I mean, we're trying to design a Medicaid data system that is not going to just last for last year, but for the next decade, let's hope, maybe a couple of decades. I don't know. I mean, again, the last system, major change in the specifications for the MSIS data really happened a couple of decades ago. So this may be the point at which we're seeing the transition with the next system. So some of the questions that I have are things like a gap that has existed in the past on encounter data is the actual payment levels have been taken off. I don't know whether that's going to be fixed. So therefore, given that the majority, so those will be there. Okay, that's great. That's important because the majority of people on Medicaid are now sort of being served through managed care programs. So we didn't actually know what the actual payments were. There are all sorts of add-ons, and particularly as we move to sort of thinking more and more about value-based payments. Is there the ability to integrate information that may have to do with things like withholds or bonuses, et cetera, that may be paid back to providers that actually reflect the true expenditure that's being made, but that aren't necessarily well linked to direct services or services on a claim-by-claim basis? This has been a problem for a long time with Medicaid dish payments, with upper supplemental payments, et cetera. There's this often big gap. And so, in many cases, billions and billions of dollars in expenditures that are not recorded in the claim system very easily. And how to link them is not straightforward. And if there are ways to help sort of link that, or at least point out where these things might apply so that you could figure out how to do an add-on, that could be very helpful too. A final question is, let's face it, I mean, claims, to be honest, are getting sort of old-fashioned. I mean, these days, many people think the world is electronic health records data. So there are obviously barriers. We don't have EHR data from everyone in Medicaid. Systems can't talk to each other very well yet, but we're getting better over time. So, one of the next questions is, will we be able to get some sample, at least, of electronic health records data that will include things like, right now we may know there's a Medicaid patient, they got this drug, they got this service, but we don't know things like their blood pressure, their cholesterol levels, their health status in any more detail. That would be very helpful, as well as the other social information. This will be a huge challenge. This is not going to be addressed, I don't think, in this version of T-MSIS. But these are some of the questions that we need to think about. How can we sort of keep moving forward to have this system available over time? That's it.
Thanks, Layton.
Okay, I take the red line in, so I think it's a sort of a safe track around Rockford Park. But I think my overall assessment in some ways is very similar to Layton's. Like Layton, I want to start by thanking CMS and NPR for inviting me here. Unlike Layton, I need to start with a disclaimer that nothing I have to say should be taken as representing anybody else represented by the seal, but should only be seen as representing my own opinion. And that opinion is that there's a great day coming, but we're not there yet. We're getting closer. Why do I think the day T-MSIS data is available to the Medicaid community will be a great day? There are 5 reasons that you've heard already. One, that T-MSIS will provide reliable data much sooner. Vivian explained why it will be reliable for all the data checks built in. Jess's example of the state snapshot showed how much sooner it will be available. There's a 6-month lag between the date it was taken in June 2016 and the date shown, December 2015. In contrast, under the current era, MACS data for 2011 became available this year for all states but Colorado. So 5 years, and yet not all states. And people with Medicaid have learned to live with this, but it's good to know that it will be shorter. That, in turn, will make it easier for people like me to argue for devoting resources to Medicaid research as opposed to research on other kinds of health care, which have not had this great lag. It's very hard right now to argue to people who control money, spend money to know what happened in 2012. That was pre-January 1, 2014. That was pre-Sovaldi. Very different world. Okay. Second, encounter data. It's been the case for several years that most Medicaid enrollees were in managed care. More recently, it's become the case that most Medicaid spending is on managed care. And yet, we haven't had good data on what's happening in that world. In the absence of good data on what's happening within managed care, we've had to assume that findings from fee-for-service data apply. Maybe adjusted by state and eligibility group, but still, taking data on these people and assuming it applied to those people when no one believed that. Only because we had no way to say anything better. So now we will. The third, fourth, and fifth reason why this is better are the three additional files that have been described. The basic structure of T-MSIS includes the 5 files, what's called a person summary on people, linked to the 4 basic claims files. That's continued from MSIS to MACS to T-MSIS. But now adding the provider file, the file with information on managed care plans, and the third-party liability file. Some of what you'll be able to do with these are things that you could do in a very convoluted way. For example, by matching MSIS provider IDs to NPI files with information about providers, but that took a lot of effort, and there's no guarantee that any 2 researchers would do it the same way. Now we're going to some standardized things that are built in. So that's 5 ways in which this will be much better. But I said we're not there yet. The T-MSIS timeline, which was part of the packet, is very helpful. But it shows 18 states in production, which means 33 are not. 33 that are not include California, New York, and Texas, each of which has a fairly large Medicaid program. Beyond that, even for the states that are in production, the broader research community does not yet have data in hand. This morning I checked the ResDex site, and there's still no information, no reference to T-MSIS, no mention of how you go about getting these data as people have gone about getting MSIS and MACS. And because of that, we don't yet have groups of researchers who have developed programs in what Carol called eras 2 through 6, who are out there making sure their programs work with the new data and taking advantage of all the new capacities that aren't there yet. And to make that happen, there'll be a transition period in which programmers and analysts work to see that their programs they developed before work with this and to exploit the new capabilities. We don't have documentation yet that looks like the MACS documentation with all the values, what they mean, and all that's the anomalies have been identified and the accumulated knowledge of how the variables may or may not capture exactly what people talk about. So I think that's all coming, but I don't have it. No one in this room outside of TMS and NPR has that at this moment. The document in the packet is very helpful, and I think what would be even more helpful would be to build on this, to have a document that has a row for each state plus DC, and a column for each year from 2010 through 2020, and then each cell shows, will this be MSIS, MACS, T-MSIS, and if it's not available right now, when will it be available? For research planning of the part that we and others inside and outside government are doing right now, that's going to be very important to know what will we have in hand when. So one step that I think could happen is development of that document and promulgation of that, even before the data themselves can be shared. Once we get to that point where we have T-MSIS data in hand, at least for these 18 states, what should we do? I'll suggest some areas, but that's based particularly on the things I see in my work. There are other things like disability that I don't get involved with because of the way our organization's up. So it just doesn't mean to say that anything else that's not on this list is not important, but these things are. One is the impact of Medicaid expansion, including the welcome out effect. In 2010, no one said this is going to be an option, but the Supreme Court decided effectively it would be. And that means that state by state, there are decisions about whether to participate or not. 32 states, counting DC, are in, 19 states are not. All the 19 and maybe some of the ones that are not in the 19 are discussing this. And it would be good to have data on who enrolled, what kinds of expenditures they had, what kind of services they're getting. In the absence of data, projections made in 2009 or 2013 or stuff people just make up dominates the discussion more than they should. Second would be spin-off of that some states expanded on the basis of waivers, which allowed them to do things a little bit differently. And it will be good to draw on all this information to assess what impact those had, how those states look different from the other states that expanded. Each of those waivers had some terms about how it would be evaluated, but not necessarily including the full sort of comparison. The other two very quickly, would be all projects that assess all the changes in the ACA besides Medicaid expansion, things that apply to states where they expand or not, like movement of kids from CHIP into Medicaid, or the end of asset limits for non-disabled adults. Lastly, the impact of the hepatitis C drugs, first developed in 2013, in Medicaid in a big way in 2014, curing the disease so that they're very effective but also very expensive, with offsetting costs that we would like to be able to quantify.
Thanks, Ken. And thanks also for wrapping up quickly. I know it's been a long session already, and we want to have some time for questions and answers. We're going to start in the room, but then we're going to alternate with people on the web, so people on the web can use their Q&A feature. And Steve has a mic, and we have a question up here in the front. Well, why don't we start with Jim and then come back here? Enough room for.
Hi, I'm Jim Rashofsky from Mathematica. Could you speak to the how the change to T-MSIS is going to affect our ability to track Medicaid over time? Will MACS data be comparable to T-MSIS, or TAF data is it called? And also, are there going to be any holes between the MACS data and the new T-MSIS data?
Sure. So those are great questions. So I'll answer the second one first, which is no gaps. Wherever a state dropped off in their MSIS submission, some of them it's been a while, but all of them at the very least stopped in October, before October of 2015, because of ICD-10, they stopped there. All of them have to start T-MSIS with the next month after they stopped MSIS. So you have a state like our friends in Colorado who have quite a ways to go back to submit their data to catch up to current. So that was very important to us, that we have no gap. Secondly, the same initial data elements that are in MSIS are still in T-MSIS. So we didn't take anything out. So if you were longitudinally studying something from 2012, 2013, you want to carry it forward, you would have the ability to do that. And we will maintain some of the other structural tools that you would need to be able to do that longitudinal look back as well. We obviously share Ken's desire to look at expansion, so the 2012 to 2014 and on time period is critical, so that's a very good question. So what that means also is that I think it reinforces Ken's suggestion about having a table that shows which state's data is available in which format, because if you're looking at, say, Colorado's data from 4 years ago and, say, Texas's data, and one was submitted in MSIS and one was submitted in T-MSIS, that's something you should be aware of potentially as a researcher, because of the validity checks that we've done in T-MSIS that may not have been there in MSIS, or the state's own capacity to make some changes might be better now than it was before, and so forth. So that is something to consider, the source of the data, like how it was inputted, not just that the same data elements are there.
Thanks, Jess. Keenan, is there a question from the web audience?
There is. It was mentioned by CMS that they're now sharing T-MSIS data with CMS stakeholders. Who are these stakeholders, and when will this data be available more widely to research organizations or even to the general public? And as sort of a follow-up, will the system cost money for those outside of government to access?
Great questions. So the data is being shared internally within CMS. So we have our Center for Program Integrity, we have our Center for Medicare and Medicaid Innovation, our actuary, our duals office, and so forth. They all have clear and critical needs for that data. So that's been our primary in the pecking order. That's our top of the totem pole. What I meant by the things that we have shared publicly are things like that data snapshot. So we've put that up in various presentations to say, like, these are the kinds of things that we can very quickly, easily do with T-MSIS data, and the team has talked with those states as well before they put that out, because that's a very important consideration for us as stewards of the state's data. Our timeline to start releasing, so we have both reports that are static and then data elements, data itself. In 2016, we are focused on the reports, and in 2017, we will start with the actual data itself. And I can't tell you exactly when in 2017, But that's when we're targeting having that work done, and the prioritization of what comes out, what data in which format first is part of what we're gathering your input on now. As far as whether we will charge for that data, again, it's not our data, it's the state's data. We are exploring our options in making the data that is at the beneficiary level that people would have to go through another tool or another organization to get to it. We're exploring what those options are, but obviously things that we can just put out on data.medicaid.gov, those are aggregate files, those are going to have no cost, data marts, things like that.
Thanks. We had a question up here in the front.
I'm Marcia Simon, and I'm a consultant. And I work with a number of CMS contractors as clients. And one of the casualties of MSIS, which people in this room may not be aware of, was the Medicaid integrity contractors, or at least half of them. The review mix, as they were called, fell by the wayside because the data that they were using, which was derived from the MSIS data and then worked over by, I think it was the University of California, San Diego, creating a data set for the review Medicaid integrity contractors to use to try to identify payment error in the system. And so my question is, where does the new data set stand with respect to it being useful and usable by the Medicaid integrity contractors, which have now been folded into a broader contract called the Unified Payment Integrity Contractor, if you can follow all this alphabet soup. Many policymakers on the Hill have said that and you said something to that effect as well, that the highest priority for T-MSIS is for use by program integrity contractors. So just would love to get an update. Thank you.
So I don't have specific information about that contract and that contract's access. What I can tell you, what we're doing with the data and then what states are doing. So what we're doing in bringing it in, our Center for Program Integrity has a couple different pots on the fire. One is clearly to look at both the providers and the services provided to people who are dual eligible, and also providers who are dual participating. So could they really have seen 20 clients for Medicaid and 20 clients for Medicare on the same day? And being able to match MPIs, it allows for those kind of impossible day analysis. And then same thing on the dual eligibles themselves to see what that looks like. They're also working on creating some of their algorithms that they can then, using the T-MSIS data, again, now we have a common language, to share it with the states themselves. These are the ways that we think you could pick up on these kinds of potential fraud flags. And we have a partnership with with DOJ for the Medicaid Integrity Institute, which is the way that we share that information with the states. So they're working on that as well.
It's in a demonstration phase.
No, so those aren't demos. Like that's the actual, we believe that's our work to do. That is not something we are testing. We have to do the comparison of Medicare and Medicaid providers and to look for program integrity on the dual eligibles and to provide that technical assistance to states. So that has to happen. So they've already started working on the crosswalks between the two data sets and mapping that out, and they have some of the early states data to plan that. States themselves already have this data, obviously, since they're giving it to us. And I know they have contracts themselves with entities that look at program integrity for them. I don't know, to your point, to your question, whether or not there's going to be some consolidation to facilitate that to the program integrity contractor.
We need to move on. Sorry, you guys make a follow-up.
But do follow up with me if you have
And the
additional
reception
questions. Glad to.
afterwards. So, Kenan, do we have another question for the web? I think we have one more question.
Is there cross-validation between T-MSIS and other data sources? For example, are Social Security numbers submitted in T-MSIS compared to the Social Security Administration's records so that they are known to be correct? Or another example, will the T-MSIS data be compared across other Medicaid reports such as CMS 64 forms?
Why don't you do the first one and I'll do the second one?
Sure, yeah. There have been efforts across time, actually. Within Max, there was even comparisons across files. And then, I mean, I guess historically that has happened and will continue to happen. But
Right, I mean, this is the data that the state has reported to us that they have validated when somebody applies for Medicaid coverage. If they provide their Social Security number, that is validated with SSA as part of that process, particularly under the new ACA rules, and then they provide that data to us. So we have certainly an interest in making sure that data is valid, but again, I'm noting we don't want to change the data. It's not ours. We would rather flag that there's an issue with this Social Security number than go in and change a primary data field. And then in terms of comparison with the CMS 64, I'll give you the 30-second version of that because it is not the same. They're not apples to apples, and I think that's a big misconception. So T-MSIS shows us the amount that states have paid on claims and other things, to Leighton's point, right? Other costs that have gone out or to their managed care payments under capitation. So that's not the same as what they claim from CMS in terms of their costs. They aren't in the same time cycle. We go on a quarterly drawdown, and that's not necessarily the final action claim timing that you would see in T-MSIS. So while there could be ways to use the 64 data as part of the triangulation that Vivian was talking about, they're not side-by-side comparable.
Right. I'm sorry we don't have time for more questions. I'm sure there's a ton of them, but there's several ways to get your questions to us. Keep sending them in. We'll compile all the Q&As that come in through the webinar. Send them to the authors. The emails are in the slides. And if you're here, there's a little card in your packet. You can fill in the card where there's not much space for your question, but you can try the blank back of the card for a longer question. I would like you all to join me in thanking our panel very much. Thank you.